Hi, I'm Dr. Maya Artandi, and today I'm going to demonstrate a 10-minute moment for dizziness. The 10-minute moments were created to help assess physical examination skills. They contain a faculty development part and an assessment part. Assessment and giving feedback are integral parts of medical education. We are all very busy, thus assessing and giving feedback on a learner's physical examination skills should be easily integrated into the clinic flow or in patient rounds in the hospital. Taking a good history is important and greatly aids in making the correct diagnosis. However, the 10-minute moment is specifically used to assess physical exam skills only. It does not include history-taking skills. Let's get started. This patient comes to clinic with the acute onset of dizziness that has lasted for 3 days. Your learner is tasked with doing a physical exam to narrow down the diagnosis. Now, the initial step in evaluating a patient with any physical concerns is to observe the patient. Does the patient appear sick? What is the patient's appearance like? Does the learner evaluate and comment on the patient's mental status? This can be assessed with observing the patient's speech fluency, train of thought, and alertness. A key goal in the initial assessment of dizziness is to differentiate between cardiovascular and neurological etiologies. Vitals are a very valuable source of information. Did the learner look at the vitals? Especially in a patient whose main complaint is dizziness, obtaining orthostatics is crucial to evaluate for orthostatic hypotension. To evaluate the patient with dizziness, it is important to perform a cardiovascular exam. Did the learner check for arrhythmia? Listen for a heart murmur? Did the learner listen to the patient's lung and evaluate the patient's fluid status? Let's get started with the exam. Once it has been determined that the patient's etiology of dizziness is most likely not cardiovascular, the next step is to try to distinguish vertigo caused by a central etiology from vertigo caused by a peripheral etiology. To do this, it is essential to perform a thorough neurological exam. If a patient presenting with dizziness has no other neurological abnormalities on exam, it is very unlikely that this patient has a stroke. It is important to have structure to the neurological exam to make sure to not forget anything. It is always important to let the patient know why an exam maneuver is done. I found that once the patient understands what is being examined and why, the physical exam is much easier and the patient much more reassured. It is also important that the learner makes sure that the patient is safe during the exam and, if necessary, assist to prevent the patient from falling. Let me demonstrate a quick neuro exam. I'm going to do a neurological exam to make sure that everything is okay. Let's start with the nerves in your head, the cranial nerves. Can you take off your mask for a second?
Sure.
Thank you. Okay. Have you had any changes in your sense of smell?
No.
That's cranial nerve 1, olfactorius. Any changes in your vision recently?
No.
Cranial nerve 2, opticus. Let me shine a light in your eyes. Please look at this. Very good. Good. That's cranial nerve 3, oculomotor. Now follow my finger with your eyes in a big circle. Beautiful. Cranial nerve 3, 4, and 6. Oculomotor, trochlearis, and abducens. I'm going to touch your face now. Mm-hmm. Tell me if everything feels the same.
Yeah, the same.
Cranial nerve 5, trigeminus. Now I'm going to have you make funny faces. Can you close your eyes as tightly as you can? Perfect. Open your eyes, raise your eyebrows. Great. Can you blow up your cheeks? Good. And then can you give me a big smile? Good. That's cranial nerve 7, the facial nerve. Do you hear this? Mm-hmm. Do you hear this?
Yes.
Cranial nerve 8, vestibulocochlear nerve. Can you say ah?
Ah.
Good. That's cranial nerve 9, glossopharyngeal nerve. And then swallow, please. That's cranial nerve number 10, the vagus nerve. Now put your hand against push your head against my hand. Mm. Good. And this way. And raise your shoulders up. Cranial nerve 11, the accessory nerve. And now stick out your tongue and wiggle it from side to side. Great. Cranial nerve 12, the hypoglossal nerve. Your cranial nerves are wonderful. Let's move on. Let's check your coordination. And if you want to, you can put your mask back on. Now, touch my finger with your left index finger, and please touch your nose. Good. And other side, please. Right index finger. And that's wonderful. Now, please put your right heel on your left shin, up and down. Good. And the other side. Fabulous. And now, can you please follow what I'm doing? Good. And let's do the other side. And your coordination is wonderful. Let's check your sensation. Does this feel like this?
Yes.
This feels like this?
Yes.
This like this? Mm-hmm. That's great. Now we are on to reflexes. Good. Good. And your reflexes are wonderful. Now, let's move on to strength. Can you please hold your arms out like that, like you're carrying a pizza box, and close your eyes? This is called the pronator drift and tests for upper extremity strength. A patient who has upper extremity weakness, you would see the hand pronate and fall down. Great, open your eyes. Can you get off the examination bench? Please walk. Great, now walk on your heels. Wonderful. Walk on your toes. And now walk as if you want to walk on a tightrope. This is called tandem gait. And that looks great. And then can you please put your feet together and just stand there? Fabulous. And your neurological exam looks great. Can you please sit back down? If the neurological exam does not show any other neurological abnormalities, the learner then needs to determine if the patient needs a Hintz exam or a Dix-Hellpike maneuver. The Hintz exam and the Dix-Hellpike exam are typically not performed on the same patient. Patients who are dizzy and have nystagmus while presenting should have a Hintz exam. Hintz stands for head impulse test, nystagmus, and test of skew. If the patient has intermittent symptoms, does not have nystagmus while sitting still, a Dix-Hellpike maneuver is indicated. Let's start with a Hintz exam. The first test is the head impulse test. I'm going to cradle your head in my hands. I want you to look at me. Mm-hmm. Keep on looking at me, and I'm just going to move your head around. Excellent. The normal response is that the eyes remain on the target. The abnormal response is that the eyes are dragged off the target by the head turn, followed by a saccade back to the target. Now, a patient with a peripheral cause of vertigo will have an abnormal head impulse test. Thus, an abnormal response is good. The next test is the test for nystagmus. I'm going to look at your eye movements. Just look at me. And now look all the way to the left and all the way to the right. A unidirectional nystagmus, meaning that the fast phase of the nystagmus does not change when the patient looks to either side, is reassuring. Usually, you will notice that nystagmus increases in frequency and amplitude with the gaze towards the side of the fast phase. The last part of the Hintz exam is the test of skew. Next, I'm going to see what your eyes are doing when I cover and uncover them. So continue to look at me. If the eye that has just been uncovered has deviated and needs to vertically realign, that's abnormal and concerning for a central lesion. If any of the three clinical signs, which are a normal head impulse test, direction-changing nystagmus, and skew deviation are present, you need to be concerned about the central lesion causing the vertigo. A patient who has episodic dizziness and does not have spontaneous nystagmus should have a Dix-Hellpike performed to evaluate for benign positional paroxysmal vertigo, BPPV. Evaluate your learner's technique and interpretation of the test. Again, it is important to walk the patient through the maneuver so they understand what is going to happen. Always emphasize that the patient has to keep their eyes open. I'm going to do another test for dizziness. Please sit up straight and turn your head to look at me. I will then quickly lie you back so that your head hangs over the examination table. Please do not close your eyes because I'm looking at your eye movements. Good. And now look at me and continue to look. There we go. And sit back up. Thank you. Usually, the patient needs to stay in the position with the head down for 30 seconds. So you can watch for nystagmus, and you need to watch the eye movements for another 30 seconds when the patient is sitting back up. The maneuver is then repeated on the other side. Nystagmus, due to a peripheral lesion, usually starts after a few seconds and does not last longer than about a minute. It is also fatigable, meaning that it will be less strong when the maneuver is performed a few times. An important part of the learner assessment is to comment on the learner's attention to the patient's comfort and well-being. Did the learner make sure that the patient was comfortable? Did the learner explain the different maneuvers to the patient? This concludes the assessment of the exam for dizziness. Thank you for watching.